Mabuhay. Pediatric pain treatment in trauma presents a unique set of challenges. The effective treatment of pain in children necessitates proactive measures, including the implementation of non-pharmacologic approaches. Recognizing pediatric patients' distinct physiological and psychological needs is essential for developing a comprehensive pain treatment plan that minimizes discomfort and enhances recovery. Join us this evening as we hit the brakes on critical pit stops in treating post-traumatic pain. I am Teddy from KK Women's and Children's Hospital and Philippine Children's Medical Center. I will be your technical director for tonight's webinar. Professor Anuradha from Indira Gandhi Institute of Child Health from Bengaluru, India, is with me as co-track director. Before we officially begin our webinar, let me share with you some housekeeping rules before our session. You can key in your questions or your suggestions or your comments or your experiences in our Q&A section. The chat and raise hand functions are both disabled. Our moderators, myself and Dr. Anu, will highlight your questions to the appropriate speaker during panel discussion. Some questions will be answered by text with the appropriate speaker in the Q&A section. There will be poll questions that we will share later. You will be prompted to answer the polling questions when a poll is launched. You will have 30 seconds to respond and submit your answer. We will share the results soon after we end the poll. After the result is shared, you may close the poll so that you can see the slide shared by our speakers. The certificate of attendance will be automatically generated and forwarded to those who submitted the post-webinar survey. And the post-webinar survey will be emailed tomorrow at 5 p.m. Singapore time. Please ensure that you have keyed in correctly your full name and email address. This session is recorded and it will be shared in our Facebook page, YouTube channel, and website. Please visit, like, and follow us. Now we will proceed to the main part of our webinar. To better illustrate the critical stages in the recovery of a child who has experienced a traumatic injury, we will follow the journey of this patient. This is a 10-year-old boy who was involved in a polytraumatic road traffic accident. He was run over by a heavy construction truck and suffered several significant injuries. We are privileged to have 4 experienced drivers with their respective specialties this evening. They will highlight treatment techniques for the case that we just shared at various critical stages. Let me hand over the floor to Dr. Anu to introduce our first speaker.
A very warm good afternoon, good evening, and good morning to all of you who have joined us for this webinar. Thank you, Teddy, for the wonderful introduction. It's very important topic today about pediatric pain trauma. So we have with us Dr. Professor Paediatric, Mr. Senior Consultant in Hospital and Emergency Department in KK Women's and Children's Hospital in Singapore. She's a clinical associate professor in the US Medical School. And he was on Institute of Medical and College School of Medicine. It's also a it's a course study together. We hospitalized at one point. She holds various positions in the Academy of Medicine in communication guidelines and she has also been communication company. And she's also a foundation assassination of this. Ma'am's clinical survey, the acquisitions engagement on training, pediatric recipe resuscitation, the privilege to have the meeting of the history for this scenario about this child was with the full group of training characters.
Hey, hi, Anu.
Yeah, hi. We'll just go ahead. We'll just go ahead to the poll question. I'm sorry, I think I'm stuck. Yeah, I see the poll question now. So can you hear me well?
There's a little bit, the audio is not very clear. Maybe I can
Okay.
help you with sharing with our poll question. Is that all right?
Yeah, let's go. Can you hear me well? I'm
Okay.
sorry that yeah. You go ahead with the poll question.
It's
My
okay.
audio is
I
bad.
will, yeah. So I will launch the poll question. So this is a 10-year-old boy, like I mentioned earlier on in our presentation. And there is this patient had cyclists on the road collided with a current cement truck, rolled over by a truck. And on arrival in CE, these are the following presentation of the patient. So the patient has GCS 15, the BP and heart rate are as follows, 80/55. And the pulse is present, extensive erythema, large, deep laceration, and right leg deformity with large open wound. So the question that Dr. Tham wants, wish to ask is that how should the paramedics manage the child's pain? So the first option is the fracture immobilization with splints and intranasal fentanyl, 1 mic per kg at scene. It could be a non-pharmacologic interventions, including fracture immobilization at the scene with morphine of 0.1 milligram per kg en route to the hospital, or it's a non-pharmacologic interventions, including fracture immobilization with splints, and consider intranasal fentanyl if the hemodynamic status improves en route to the hospital. And the last option is secondary survey and pain management en route to hospital using Penthrox inhalation, as a GCS is actually 15. So I think all of our participants have keyed in their answers to the question. I will share now the results. All right, can I call in Dr. Tham? Hi, Dr. Laiping, good afternoon. Welcome to our PPSIG webinar. If I may check on the answers, the majority of the answer, 50% of our attendees answered the third option, which is the non-pharmacologic interventions, including fracture immobilization with splints and consider intranasal fentanyl. What do you think about this, Dr. Tham?
Good afternoon, everyone. Thanks for having me. Yes, this is the correct answer, actually, because in the pre-hospital setting, there are many challenges, and actually the main priority is to stabilize the patient, treat all the life-threatening injuries. And so after that, then when en route to hospital or during the secondary survey, pain management is definitely important. And non-pharmacological intervention is actually one of the most important thing in the pre-hospital setting, because with medication, there's also side effects that comes with it. And many of these polytrauma patients are unstable patients, hemodynamically challenged, and also the CNS is not normal a lot of times due to the head injuries. So yes, this is the correct answer.
Thank you very much, Dr. Laiping. And now we will proceed and listen to your lecture, and we will learn more tricks and tips from our specialists. Thank you.
I'd like to thank the organizer for inviting me to speak in today's ASPA webinar on the topic of pre-hospital and emergency department assessment and management of pain in pediatric major trauma. I'll start off with a case presentation of a patient that we manage in the hospital. This is a 10-year-old boy who's a cyclist on the road, collided with a cement truck and rolled over by the truck. So he was found prone with the lower part of his body trapped under the wheel of the truck after the truck reversed upon hitting him. So the child was wearing a bicycle helmet during the collision. He was extricated within 10 to 15 minutes. On arrival of the EMS, he was conscious, GCS was 15. His vital signs were heart rate of 150 per minute, RR of 18 per minute, SpO2 of 96% on room air, and his blood pressure was only 80/55. The pulses was present, the lungs was clear, there was no visible scalp hematoma or laceration, but there was an extensive erythema and bruising over the entire chest, and there was facial congestion. There's a large, deep laceration on the left abdomen flank extending to the gluteal region. There was no spurting noted, but his right leg was deformed. mangled with a large open wound. He was able to move his toe, but he was in a lot of pain. So what are the immediate priorities in the management of this child at the pre-hospital phase? And how should the paramedics manage the child's pain? So during the pre-hospital phase, providers need to emphasize quite a number of things: the airway management, control of external bleeding and shock, immobilization of the patient, and immediate transport to the closest appropriate facility, preferably a verified trauma center. And pre-hospital providers have to make every effort to minimize the scene time, notify the receiving hospital before the personnel transport the patient from the scene, and the use of pre-hospital care protocols and ability to access online medical direction, that is direct medical control, can facilitate and improve care initiated in the field. But we know that pre-hospital pain management is a vital part of the patient care, and to provide optimal patient care, pain should be correctly assessed and treatment options for pain relief should be considered and then applied. How should the pain be assessed? So there are a few pain rating scales. So the gold standard in pain assessment is the self-reporting of pain. So for verbal children that's 3 to 7 years old, we can use the Warm Baker Faces pain rating scale. So we can get the child to point to indicate which face would most represent his level of pain from a scale of 0 to 10. So for verbal children 7 years and above, then the numerical rating scale would apply from a scale of 0 to 10. And for children who cannot verbally express themselves, look for pain cues. That includes facial expression, frowning, grimace, vocalization, moaning, groaning, crying, physical actions such as guarding, limited mobility, restlessness. So for very young children, 2 months to 3-year-old, the flex scale can be used. And so this is by using the facial expression, vocalization, and physical action of the child. So EMS providers should carefully evaluate these clues and develop an appropriate pain management strategy based on all available information, including clinical status and vital signs of the patient, and also mechanism of the injury. So for pain management in the pre-hospital setting, once all life-threatening issues have been addressed, then the pain management can be started. You can always start off with non-pharmacological interventions first, communicate in a calm and reassuring manner with the patient, and relieving anxiety is very important. So the presence of a caregiver to comfort the child can help a lot, and you can distract the child with toys, videos, music, and for the young infant, pacifier definitely helps. So for painful fractures, splinting of the fracture does help to relieve the pain a lot. Applying cold packs to the contusions, sprains, padding pressure points in the spinal immobilization. For pharmacological intervention, this has to be carefully selected based on the primary indication, contraindication, possible adverse effects, the patient's overall hemodynamic status, the conscious level of the patient, the type of injury sustained, whether it's head injury, pneumothorax, musculoskeletal injury, and also very important, the skill level of the pre-hospital personnel, whether they are advanced life support trained versus basic EMT trained. For pharmacologic intervention, common oral paracetamol, NSAIDs, which can be given in the oral form, ibuprofen, IV ketorolac, or per-rectal diclofenac. For fentanyl, it can be given as an IV or intranasal. It's an opiate, often first-line agent in the advanced life support EMS system due to its fast onset and short action of duration of action. You can titrate dose to appropriate effects. The dose is usually 0.5 to 1 microgram per kilo per dose, with a max of 50 microgram per dose, given over 1 to 2 minutes, and you can repeat it every 1 to 2 hours. Intranasal fentanyl is also commonly used for children above 10 kilo. The dose is 1.5 to 2 microgram per kilo per dose, with a max of 100 microgram per dose. Morphine, that's another IV opiate that's commonly used in the advanced life support ambulances. It can be used when there's a longer duration of analgesia that's needed. Starting dose usually 0.05 mg per kilo per dose given over 4 to 5 minutes, and you may repeat it every 2 to 4 hours and titrate the dose to appropriate effects. Very important to avoid narcotic analgesic if patient has head injury, because that can worsen the CNS depression. And also avoid opiates when the patient is hemodynamically unstable because of the vasodilatory effects of the opiates. Nitrous oxide is another common analgesic that's used in the pre-hospital setting. It's available in the Antonox inhalation. It's pre-mixed in the tank, fixed concentration at 50% nitrous, 50% oxygen. It can be self-administered by the patient using a tight sealing face mask. The onset of analgesia is 3 to 5 minutes, but there are contraindications. Vitamin B12 and folate deficiency, when there is an entrapped air in the body cavity, such as pneumothorax, intestinal obstruction, then nitrous is contraindicated because it diffuses faster into the body cavity than nitrogen diffuses out. So you can actually worsen the entrapped air cavity. Altered mental status, such as in head injury, inhalational injuries, hemodynamic instability again. So once the nitrogen is completed, preferably oxygen should be administered for about 3 to 5 minutes after discontinuing the nitrogen to prevent diffusion hypoxia. Methoxyfluorine or Pentrox or the green whistle is another common analgesia that's used, especially in Australia and New Zealand by the ambulance services. But it has some minor side effects of sedation, hallucination, vomiting, confusion, euphoria, dizziness, cough, and headache were reported in some of the studies. Rare major adverse events of cholestatic jaundice and malignant hyperthermia have been reported, but more in the context of anesthesia. But methoxyfluoride has not been used as an anesthetic agent for a long time, and at the analgesic dose, these major adverse events are rarely seen. So for emergency ambulance, usually it is used when the children are above 5 years old, whereby they can cooperate and learn how to use an inhaler when they have moderate to severe pain secondary to trauma. So again, contraindication when there is clinically significant renal impairment, when there is hypersensitivity to the fluorinated anesthetic or any ingredient in the Pentrox, clinical evident cardiovascular instability, respiratory depression, altered mental status due to any cause such as head injury, drugs, or alcohol, malignant hyperthermia, whether the patient themselves are known to have it or genetically susceptible to malignant hyperthermia based on a positive family history. So how to administer this? The patient inhales through the mouthpiece, and the exhale breath is channeled through the activated charcoal absorber chamber, which also has a hole that can be occluded to increase the inspired concentration of the vapor. So the methoxyfluorine liquid is added via the base of the inhaler tubing through the base of the inhaler, and also at the same area you can also add on supplemental oxygen with the tubing here. So for dose, the pediatric patient up to 16 years old, the dose is 3 mL per dose. The inhaler dispenses 0.2 to 0.4% with the diluter hole open and a higher concentration when it's closed. Generally, each of the 3 mL should last about 25 minutes. So in this pre-hospital study that looks at the effectiveness of pre-hospital morphine, fentanyl versus methoxyfluorine in pediatric patients. So they have 3,000 over patients, aged 5 to 15 years, with moderate to severe pain, with a pain score of 5 and above, that receive this 3 medication, either alone or in combination. And the primary outcome is 30% reduction or more in the initial verbal numerical rating score. So they find that for methoxyfluorine is effective in 78.3% of the patient, as compared to morphine, which is 87.6%, and fentanyl, which is 89.5%. So in this multivariate logistic regression analysis, they find that methoxyfluorine is less effective as an analgesic compared to morphine and fentanyl. So the authors concluded that it is less effective in comparison with both IV morphine and intranasal fentanyl, but is an effective analgesic in most of the patients. So in this evidence-based guideline for pre-hospital pain management recommendations, so they recommend in favor of intranasal fentanyl over intramuscular or intravenous opiate in the treatment of moderate to severe pain in pediatric patients prior to IV access or without IV access. The panel makes a conditional recommendation for either intranasal fentanyl or IV opiates once IV access is established. So in summary, for pre-hospital pain management, a balanced approach using appropriate pain management, avoid narcotics whenever possible, and applying non-pharmacologic options frequently should be the strategy. So the pain management options selected should be based on efficacy and safety and should not interfere with life-saving treatment or rapid transport to an appropriate receiving facility. If any analgesic medications are administered, then monitor the vital signs closely, and if available, end-tidal CO2 as well. So back to our case presentation of the 10-year-old boy with the shock as shown by hypotension, tachycardia, with the extensive injuries over the chest, the abdomen, and also an open fracture of the leg. So the immediate priorities for the pre-hospital team should be to assess and manage all life-threatening injury. So the airway, oxygen mask should be given, supplemental oxygen to keep the SAT-SOT up. Cervical collar, spinal immobilization should be performed. Direct pressure and bandage applied over the large abdominal and flank wound and the right leg wound. IV access and IV crystalloid normal saline 20 mL per kilo bolus should be administered to bring up the blood pressure first, and standby activated for the nearest trauma center in view of the patient with hypotension. So the secondary survey and the pain management can be done en route to the hospital, and non-pharmacological intervention are important in this patient in view of the hemodynamic instability of the patient. So it's important to communicate in a calm and reassuring manner to the patient. Fracture immobilization with splints, padding the spinal board to reduce pain and pressure on the flank wound, continuous monitoring of the vital signs and the GCS, pharmacologic intervention. IV opiate worsens the hypotension and may cause respiratory compromise in view of the possible chest and head injury. So methoxyfluorine inhalation may also induce CNS effect, which again may affect the monitoring of the GCS. So intranasal fentanyl, single dose, may be an option after improvement in the circulatory status, and perhaps Pentox can be a consideration as well once the hemodynamic status is stabilized. So on arrival of this patient to the ED, the patient is still hypotensive with the blood pressure of 85/59, tachycardic 149, SATs are maintained on supplemental oxygen. GCS is still 15. Trauma code activation was done. Fluid resuscitation was continued with IV emergency blood packed cells. 10 mL per kilo was given, and the repeat vital signs was improved with the blood pressure of 100/64. Heart rate is still 140, and urgent CT scan X-rays performed show that the patient had a splenic laceration and hematoma, a sliver of left pneumothorax with fracture of the 5th and the 6th ribs. There's a large perineal ischial anal laceration. The right lower limb has a large degloving injury with an open tibia fracture, and there is a left abdominal wall laceration, but there's no evisceration. There is no intracranial hemorrhage. So the child is complaining of pain. So what analgesia could be given prior to the wound irrigation in the ED? So the relief for severe pain is an important part of treatment for trauma patients. And effective analgesia usually requires the administration of opiates or anxiolytics given intravenously. Intramuscular injections are preferably avoided because it cannot be used to titrate the dose, and it's also painful with each intramuscular injection. So IV opiates, though commonly used, but it has to be used judiciously and in small doses to achieve the desired level of patient comfort and relief of anxiety while avoiding further compromise of the respiratory status or CNS status and hemodynamic changes. The initial pain assessment in the ED is usually done during the triaging of the patient when they first arrived. But in emergency situation whereby the patients have life-threatening conditions, they are triaged to the resuscitation room immediately, and pain management and assessment is usually performed when the patients are stabilized. So there should be a stepwise integrated pharmacological and non-pharmacological approach to the pain management in the ED, with the initial assessment of not just the child's pain, but also assess whether the parents' anxiety and whether they are able to assist in comforting the child. So if they are able to assist, then initiate pharmacological treatment, coach the parents in comforting and calming the child, and begin non-pharmacological interventions to alleviate the distress, ideally with the parents' collaboration. And then reassess the effectiveness of the pharmacological treatment and non-pharmacological intervention, and with periodic reassessment. So in a pain ladder, for mild pain, usually non-opiate analgesics such as paracetamol and NSAIDs will be enough. Moderate pain, very often opiate needs to be added. And severe pain, higher dose of opiate besides non-opiate analgesics, and also adjuncts such as nerve block very often helps. So for pharmacological intervention in the ED, paracetamol is one of the most common, but in major trauma, IV would be more useful, and the dose varies from the higher of 15 milligram per kilo per dose 6 hourly for the older kids to 7.5 milligram per kilo per dose for those that's neonates. Just a caution in those patients with deranged liver function tests, especially if prolonged use. Ibuprofen can be added on to paracetamol if the pain is assessed to need both analgesics. But again, caution in patients with platelet dysfunction, active bleeding tendencies, renal impairment with dehydration, concomitant use of nephrotoxic drugs, whereby NSAIDs can potentially worsen these side effects. Opiates, as we've mentioned, fentanyl, that can be given IV or intranasal. So because the analgesic effect wears off at about 45 minutes to an hour, so it'd be good to administer an oral analgesic 15 to 20 minutes after the intranasal dose. That may help to provide a therapeutic overlap. For IV, fentanyl usually is given at the dose of 1 to 2 microgram per kilo with a max of 100 microgram. Morphine, another common opiate that can be used IV per oral or intramuscular. But in children with severe pain, IV access should be established so that IV opiate in titrated doses can be given. And again, the dose varies for those smaller kids. IV morphine 0.05 to 0.1 milligram per kilo per dose, slow bolus. For the older kid, usually is given at an initial dose of 2 to 5 milligram every 2 to 4 hours. Caution if you are using it in patients with pre-existing respiratory compromise, obstructive sleep apnea, morphine potentially can actually worsen the respiratory depression. Infusion can be given for morphine. This can be started for patients who are in constant severe pain and they are kept nil orally, usually started at the dose of 20 microgram per kilo per hour. But if there are concerns over sedation and all that, then that can be decreased by 50%. Ketamine is a very useful medication to be given in the ED for pain, for sedation. It's a non-competitive NMDA with and a glutamate receptor antagonist. It provides dissociative sedation, and it also can be used as an analgesia medication. For procedural sedation, then patient selection, usually normal and healthy patient, ASA classification 1, or patients with mild disease that is well controlled, ASA classification 2. For dissociative sedation, IV ketamine is given at the dose of 1 to 1.5 milligram per kilo, but give it as a slow bolus over 30 to 60 seconds. And if additional doses are needed, then it's given at 0.5 milligram per kilo. And this can be given every 5 to 15 minutes to a max of 5 mg per kilo. For intramuscular ketamine, we start off at 3 to 4 mg per kilo, but it can go up to 5 mg per kilo. Additional doses, which is half of the initial dose, can be given at least 10 minutes after the initial dose if inadequate sedation or repeated dose is needed to accomplish a longer procedure. So when do we give IV or intramuscular ketamine? So intravenous ketamine is not administered until the physician is ready to begin the procedure, because the onset of dissociation typically occurs rapidly. So in settings in which IV access can be obtained with minimal upset, less than 3 attempts, then IV route is preferable because the recovery is faster and there is also less emesis. The emesis rate in children for intramuscular ketamine is almost 20% when they are older than 8 years old, and this has been shown in a study that we published using our local cohort of patients. Compared to the younger kids, that is at 8.4%. The intramuscular route is especially useful when IV access cannot be consistently obtained with minimal upset, and for patients who are uncooperative, combative, so for example, autistic children, then it will be easier and kinder to just give it as an intramuscular dose. Prophylactic ondansetron can slightly reduce the rate of emesis. The numbers needed to treat is 9 or more. So do consider prophylactic IV ondansetron, especially if the child is more than 8 years old. Intranasal ketamine has been used increasingly. In this double-blind randomized active control non-inferiority trial in Paediatric Level 1 Trauma Center, they found that when they compared intranasal ketamine at a dose of 1.5 milligram per kilo to intranasal fentanyl at a dose of 2 microgram per kilo, they found that ketamine provides effective analgesia that is non-inferior to fentanyl. However, the adverse events are increased in the intranasal ketamine group, although they are usually minor and transient. So ketamine should be considered for pediatric pain management in the emergency setting, especially when opiates are considered associated with increased risk. So in this other randomized control trial of also intranasal ketamine compared with intranasal fentanyl, this paper, they use a lower dose, which is 1 mg per kilo for intranasal ketamine. And for the intranasal fentanyl is 1.5 microgram per kilo. And they find that intranasal ketamine was associated with more minor side effects, bad taste in the mouth, dizziness, sleepiness, than compared with intranasal fentanyl. But pain relief at 20 minutes was similar compared to both groups. IV ketamine can also be given as an infusion for sedation purposes, for analgesia in critically ill pediatric patients, especially in the ICU setting, whereby initial dose of 0.5 to 2 milligram per kilo can be started, then followed by continuous IV infusion of 5 to 20 microgram per kilo per minute. Usually we start at the lower dose and then titrate to effect. This can be useful for patients with major trauma, post-intubation, and we need analgesia and sedation. Nitrous oxide sedation is also commonly used in the ED, but in the ED setting, often we use the continuous flow mixer, so the nitrous oxide concentration can go between 30% to 70%, and we like to use it for simple fracture reduction, I&D of small abscesses, wound irrigation, dressing, local anesthesia injection, and the contraindication are explained earlier on. And it can also be administered together with opiates such as intranasal fentanyl. A topical anesthetic, lead gel, which consists of lignocaine 4%, epinephrine 0.1%, and petrocaine 0.5%, provides very effective local anesthetic for wound repair in the ED. So that can help to reduce the rates of sedation needed. It's applied directly to small wound less than 5 centimeter. Usually we use a dose of 0.1 ml per kilo, max of 3 ml, and wait for 30 minutes before we do the toilet and suturing. So the contraindication mainly in younger children less than 1 year old, allergy to amide anesthetic, involvement of mucous membrane, digits, genitalia, ear or nose. Local anesthesia through digital nerve block can be very useful. Also, we can use it in older children that's able to cooperate without sedation for nail bed repair, reduction of displaced fracture, dislocation of the phalanx. Definitely non-pharmacological interventions, distraction using music, video collated by child health therapies are very useful. So we have QR codes for each of the individual video and music that's available in the procedural room, in the resus room, that can be used to help to distract all the fretful and very anxious and children. So the language used is also very important by staff and also by parents, how we can comfort the children. So instead of apologizing for causing pain, we should actually use something more positive, such as you are being very brave to praise and encourage them. Just to go back to our case, our patient that mentioned earlier on. So how should the pain management for this patient be in the ED with all the multiple injuries, multiple major trauma? So the analgesia in the ED, IV paracetamol, 15 milligram per kilo can be administered during the initial resuscitation together with IV morphine of 0.05 milligram per kilo. And after the BP stabilized and just before the wound irrigation, another 0.05 milligram per kilo of the IV morphine can be given. Alternative analgesia such as IV fentanyl, 0.5 to 1 microgram per kilo, or intranasal ketamine, 1 to 1.5 milligram per kilo can be given as well. So this is my last slide. So thank you for listening. And I'll be happy to take any question later on in the Q&A. Thank you.
Thank you very much, Dr. Liping, for highlighting some pre-hospital and children's emergency pain treatment approaches that we can use upon arrival of a patient following a severe traumatic injury. Moving on to our next speaker, we are excited to have Associate Professor Albert Kwon from Stanford University with us this evening. Dr. Kwon joined the Stanford Pain Medicine faculty in 2021. His clinical focus is chronic pain care, transition from adolescence to adulthood, and chronic pain syndromes of young adults. He is also building the Stanford Adolescent and Young Adult Pain Program, a collaborative effort that bridges the Pediatric Pain Management Program in Lucille Packard Children's Hospital, Stanford, and the Stanford Pain Management Center at Stanford Hospital and Clinics, leveraging digital health solutions. Professor Kwon will share with us the acute to chronic pain transition and treatments in pediatric trauma. But before his lecture, we will be sharing the poll question that Dr. Kwon wishes to ask our audience. So for our poll question, which non-opioid analgesic do you feel uncomfortable using in acute pain in pediatrics patients? So the options are as follows. So it's either, are you comfortable or uncomfortable using gabapentin or pregabalin, clonidine or dexmedetomidine, antidepressants, ketamine infusion or systemic lignocaine infusion? You can answer more than one. You just highlight to us which particular adjuvants or non-opioid analgesics that you are not comfortable to use. You have 30 seconds to answer. Then later on, we will invite Dr. Albert to just give a comment regarding the answers of our viewers. Thank you very much. And again, we encourage everyone to please key in your questions in our Q&A box. Then later on, we will ask our speakers. Okay, 30 seconds up. I'll share the results. Can we invite Dr. Albert? I think based from the results, majority of our audience, about 69%, are not comfortable prescribing antidepressants.
That's not so surprising to me because it's more for chronic pain, but it can also be helpful for acute pain patients. I'm happy to answer any questions about antidepressants at the end of the talk.
Yeah, thank you very much. Okay, so now let's move on to Dr. Albert's lecture.
Thank you for the nice introduction and inviting me to give this talk. My talk is titled Acute to Chronic Pain Transition and Treatments in Pediatric Trauma. Uncontrolled post-injury or post-op pain or such acute pain leading to chronic pain in pediatric patients is a big fear of many providers and family members who must witness some of these patients struggle with this situation. In this talk, we will learn about biopsychosocial model of pain, clinical risk factors predicting uncontrolled acute pain and chronic post-surgical pain, and we will review multimodal toolkits for treating pediatric acute pain, including opioids, local anesthetics. We'll do a brief overview of analgesic adjuvants and non-pharmacological treatments. When we evaluate patients in acute pain or chronic pain, it is very important to keep in mind that we have to look at the overall trajectory of their pain symptom and the impact that the pain is having on their function and recovery. And pain often will veer off our expected course, and that is okay. It's important that we maintain a wide differential diagnosis in understanding why they're nociceptive pain or neuropathic pain or nociplastic pain may be presenting in that moment. So I encourage everyone to not just think about pain as just one same thing, but we must entertain all these different differentials each time. The biopsychosocial model of pain is very important because many factors can contribute to pain, including biological factors, psychological factors, and social factors. Such biopsychosocial model was first described in psychiatry for psychiatric illnesses by Dr. Engel in 1977. When we look at the pain circuitry in the neurological system, this becomes not so surprising because pain is not just about the local tissue injury or nerve injury that happens with surgery or a traumatic injury, but also there are many other factors such as genetic or psychological predisposition, secondary changes that happen in the spinal cord, brainstem, midbrain, and the cortex as a result of ongoing pain experiences that can then propagate chronic pain in patients. And this is also very apparent in our clinical practice when we see acute pain patients after surgery. These are graphs of patients who had surgeries. This was a paper out of Stanford studying adult patients, but tracking the first 10 days after their surgery, one can see that there are many different trajectories and wide range of pain scores reported. And using data analytics and large data science, this paper kind of classified patients into high acute pain and low acute pain populations, and then followed them for 2 years after their surgery. And it has become apparent that those who report high acute pain in the first 10 days have a very different recovery trajectory compared to those who reported low acute pain levels. Those who reported higher acute pain had slower pain resolution and opioid cessation. When looking at the patient's characteristics that may predict whether a patient may be a high acute pain group or a low acute pain group, history of alcohol or drug abuse treatments prior to the surgery, and contrary to popular beliefs, being female was associated with higher acute pain scores, and existence of preoperative pain due to chronic pain or ongoing acute pain also predicted higher acute pain scores after surgery. When looking at post-op day 10 and the worst pain reported, those reported high worst pain on post-op day 10 was the best predictor of slower pain resolution, slower opioid cessation, and slower complete surgical recovery. In children, persistent pain after surgery is also very common, surprisingly. About 20% of pediatric patients reported post-surgical pain persisting after 12 months after a major surgery. And even in this study, the pre-surgical factors that predispose patients to have post-surgical persistent pain included high elevated pain prior to surgery due to chronic pain or their ongoing injury, child's anxiety and poor pain coping efficacy, and also parental pain catastrophizing behaviors were associated with developing persistent persistent pain after surgery. Looking back, because a lot of the pre-surgical factors have to do with psychological and social factors, it is very important to approach even acute pain with the biopsychosocial model. And those with injury and post-traumatic pain is also the same. Now let's shift our focus to looking at the biological toolkit, which in medicine, analgesics plays a big role. As we study the pain circuitry and how there are different mechanisms at different junctures in the ascending pathway of the pain signal, we can come up with many different classes of analgesics that could alter the pain signaling as outlined in this figure. But today we'll go over four big categories. One is opioids, and it's very important that we recognize opioids are the workhorse of acute pain treatment still, although there's been a lot of pushback on opioids in the United States. I think opioids should be, acute pain physicians should be very well versed with opioid management. There are many different delivery methods for opioids: intranasal, intravenous, oral, transdermal. There's some other transmucosal routes that we don't necessarily use all that often among pediatric patients. But within the hospital setting, intravenous route of administering opioid is very common. It could be delivered intermittently through an IV, or one could set up a patient-controlled analgesia machine, or if the patient's disabled or are developmentally inappropriate for a PCA, then a nurse or an authorized agent who are well educated and trained may be able to help assist with controlling the analgesic delivery. It is important to recognize that not all opioids work the same for everyone. At least in adults, there are many different genes that were identified that alter the effects of opioids. In pediatric population, the COMT gene and single nucleotide polymorphisms were associated with a subset of patients needing 3 times more rescue analgesics than the other groups. And even in these patients who received 3 times more rescue analgesics, Although there was a tendency for longer PACU stay, the PACU time was not statistically significant. Nowadays in the United States, methadone is a pretty hot topic, even in pediatric perioperative opioids. I think there are a number of studies that looked at methadone in scoliosis spine surgeries or cardiac surgeries. In spine surgeries in pediatric patients, there are mixed results, although it's important to recognize that probably a single change in an opioid plan would not be a universal solution for everyone. So, and that's probably why there's mixed results resulting from these studies. So it may be more important to kind of view this and approach this by looking at standardized multimodal treatment protocols such as ERAS that may be more likely to yield success across many different institutions. In cardiac surgeries, it's been shown that methadone may decrease other opioid requirements in the first 24 hours, but it's not surprising because methadone is another opioid that can be pretty potent. And methadone has been shown that it can be helpful for patients having difficulty weaning off opioids after a prolonged duration of opioid sedation in the ICU. Opioid talks must include the risk of respiratory depression from opioids. The respiratory control circuitry resides in the brainstem, and opioids or activation of the new opioid receptor suppresses respiratory rhythmogenesis, and which will then slow minute ventilation, which then will increase the CO2 content in the blood, and alveolar CO2 will increase. And that increase in CO2 will displace oxygen in the alveoli, and which can result in hypoxia and hypoxic organ damage in the patient, which could have grave consequences. One important point to make is how do we monitor for this potentially catastrophic complication? And I kind of simplify this strategy into two scenarios. If the patient's on room air, the increasing CO2 in the alveoli resulting in oxygen being displaced can be quickly picked up on the continuous pulse oximetry signal desaturating. Therefore, one should be on continuous pulse oximetry if someone's on a PCA or any kind of infusion of an opioid, or a repeated dose or a patient receiving repeated doses of opioids. But if the patient's on any amount of supplemental oxygen, even a little bit through nasal cannula, there's increased alveolar O2 content because of higher FiO2 and increasing alveolar CO2 and displacing some of that high O2 content in the alveoli doesn't show up on pulse oximetry. Therefore, it is important to recognize continuous pulse oximetry is inadequate in monitoring for hypercapnia in patients with any supplemental oxygen. In these cases, continuous end-tidal CO2 is the best monitor. However, this could be a very resource-intensive implementation in many institutions. Therefore, it's very important that the hospital looks at alternative methods of monitoring for opioid-induced respiratory depression in patients with any supplemental oxygen. Now we're going to shift to talk about local anesthetics. Regional anesthesiology is very powerful and should be employed whenever it's safe to use. This really provides pain management in a large region of the body through neuraxial techniques or peripheral nerve blocks. It's important to recognize, though, that regional anesthesia is not a one-size-fits-all solution. It can significantly decrease opioid requirement, and it can be effective in treating a targeted source of pain in a particular region of the body. However, in trauma, patients who have multiple injuries in many different body parts, regional techniques may be limited in its utility. Oftentimes, institutions will perform a single shot block, which is great for up to a day, but then it often will wear off overnight or by the next morning, and patient will be in uncontrolled pain. And it's oftentimes hard to repeat these blocks again and again once the patient leaves the perioperative setting and goes to the regular floor or the ICU. Alternatively, one may place a catheter around the nerve targets and infuse local anesthetics for 5 to 7 days. And this could be a way to prolong good regional analgesia through a catheter placement. Another strategy is to consider infusing lidocaine systemically. Lidocaine given systemically has been shown to exert anti-inflammatory effects. Many studies have shown lower levels of various inflammatory markers after surgery when lidocaine is provided systemically. A randomized control study done on inguinal hernia repair has shown good efficacy of post-op pain control with systemic lidocaine infusion versus saline. And I thought this was study done in South Korea was very well done. At Stanford, we oftentimes place catheters and infuse lidocaine through the regional catheter. And what we find that the lidocaine can exert effect through the regional block, and it gets absorbed systemically and with repeated bolus injections through the catheter or a continuous infusion, the lidocaine level in the serum rises to therapeutic levels to treat pain systemically as well. So one could imagine placing a nerve block catheter or an epidural targeting the area of pain that is most severe, and then relying on the systemic absorption to treat many other injuries around in a polytrauma patient. Local anesthetic talks must include something about systemic toxicity or LAST. LAST presents with neurological and hemodynamic symptoms and signs, and when it's very severe, supporting the neurological system, one may have to perform CPR if there's hemodynamic compromise. But most important thing to remember is that intralipid is the only treatment for LAST, and one must give this in order to reverse the neurological and hemodynamic compromise. We're going to shift gears to adjuvants and then non-pharmacological treatments, but we'll kind of blitz through these in the interest of time. There are many classes of adjuvant analgesics that are worthy of mentioning. Acetaminophen or paracetamol, NSAIDs, gabapentin, pregabalin, clonidine. If a patient's in the ICU, one may consider dexmedetomidine, antidepressants such as SNRI or TCA agents, and also ketamine infusion. Unfortunately, there aren't that many pediatric studies done to really robustly show that these are very effective agents in children or adolescents. However, there's a lot of ERAS studies that may suggest doing a multimodal approach, utilizing a number of adjuvant analgesics could be very helpful. And ERAS as well, there's a lot more studies done in adults and less so in pediatric patients, although it's been picking up some traction in the pediatric world the past 10 years. In adults, at least, there's post-traumatic laparotomy or emergency surgery ERAS studies. One that was done on laparotomy has shown that adding epidural and NSAIDs as part of multimodal pain management compared to standard recovery group that only received acetaminophen plus opioids, the ERAS group did much better in terms of recovery metrics. So far, I couldn't find any ERAS studies specifically for trauma, but there are a lot of studies for GI and spine surgery and whatnot. Briefly about non-pharmacological treatments, these group of treatments really lean in on the biopsychosocial model of pain. One such innovative treatments nowadays is VR treatments for acute and chronic pain in children. However, this is kind of like an extension of child life therapy, distraction therapy, play therapy, which already have very good evidence. And if an institution has the resource to implement any of these child life therapies, it'll be very, very helpful. Psychological interventions prior to surgery could prevent or shorten opioid use after surgery. In adults, breast cancer surgery is notorious for causing chronic pain. And there was a program called My Surgical Success delivered to these adult patients awaiting breast cancer surgery. And at Stanford, these patients have, who received the psychological intervention and education before surgery were able to stop opiates faster than those who did not. Similarly, there are these single session video conference delivered CBT based pain psychology interventions called Empowered Relief. And in the pediatric chronic pain clinic, we're starting to study this. But then this curriculum is very applicable to acute pain, such as My Surgical Success in adult undergoing breast cancer surgery. And I think that would be the natural next step to study after validating this in chronic pain patients. So there's a lot to look ahead for acute pain management. It's not just opioids and nerve blocks, but there are other modalities to study. In the interest of time, this is all I have for today. Thank you very much for listening. Please feel free to reach out to me if you had any questions or would like to talk more about any particular topic. Thank you. Thank you for the.
Thank you very much, Professor Albert, for sharing with us some pharmacologic techniques and non-pharmacologic approaches in treating patients from acute to chronic transition. Now let's move on to our next speaker. Ms. Goh Sin is a registered clinical psychologist at KK Women's and Children's Hospital in Singapore. Her clinical work and interests include delivering evidence-based assessment and interventions to children and youth who have experienced various types of traumatic events. Sin is also a master trainer in psychological first aid for children and Be the Light crisis support for children and youth since 2018. She is passionate about teaching and loves equipping others to provide trauma-informed support to children and youth. Before she begins our lecture, she wants to ask one poll question to our viewers. Children with serious physical injuries are more likely to experience psychological trauma. Is it true or false? You all have 30 seconds to answer. Again, we would like to invite everyone to please key in your questions in our Q&A box. Okay, I think 30 seconds is up. We will end the poll and then we will show the results. Okay, 97% of our audience answered it's true. How about that? I think you're muted. You can unmute yourself and give some comments regarding the answers of our viewers.
As compared to the other speakers, I want to share that all of you are neither wrong or correct. I will speak about this poll question further in the session that I'll be presenting later. But what I would like to share is that this is a trick question. We know that whether someone experienced traumatic stress reactions is really related to their perception. So meaning whether they found the event to be threatening to their body, whether they found it threatening to their life, and whether it was threatening to their identity. So I would like you to spend some time listening to the session and find out more about this poll question later. Thank you.
Thank you very much, Sin. Now let's listen to her lecture.
Hi everyone, I'm here to share with you about psychological trauma support for children today. And I hope at the end of the presentation, you will know the answer to the poll question that you just answered a few seconds ago. Before we can talk about psychological trauma, I think it's important that we first understand what constitutes as a traumatic event. The first misconception that people tend to have is that they believe that a traumatic event has to be something that is large scale, and this is not true. Traumatic events can be any situation that a child perceives as extremely stressful or life-threatening. And whether or not we perceive an event to be life-threatening It is really based on our perception of the event. Perception is defined on how we see and understand the world, and it's closely linked to our developmental level. A preschooler have a very narrow understanding of the world and rely greatly on their caregivers to understand what's happening around them. Whereas school-age child and teenagers have better understanding of the world and how things work around them. Now, I would like to share a story about this preschooler that was referred to us. The doctors had actually referred him to us because they were concerned whether this child was affected by the road traffic accident that he had just experienced. But after we saw him, we actually found out that the most distressing event for him was actually being separated after the road traffic accident from his caregivers because the ambulance had to take them to different hospitals to receive the medical care that they need. Another common misconception that people tend to have is that they believe that children with more severe physical injuries are more likely to experience traumatic stress reactions, but this is also not true. I would like to share a story about two siblings who have experienced the same road traffic accident, and they were referred to us by our team of medical doctors. So one of them have actually sustained skin abrasions, and the other one sustained an arm fracture due to the accident. The child who sustained the skin abrasions ended up the one who have actually reported about developing fear of crossing the road and would want to stay indoor all the time after the discharge from the hospital. And the sibling who sustained the arm fracture did not report any of the difficulties at all. So to summarize, the three main learning points that we have covered here is that number one, the subjective experience, which is basically our perception, is what influences whether a child would experience traumatic stress symptoms. Traumatic event can be any situation that a child perceives to be extremely stressful or life-threatening. It does not have to be a large-scale event. And number three, higher severity of physical injuries does not increase the likelihood of children experiencing traumatic stress symptoms or PTSD, post-traumatic stress disorder. This is the definition of trauma. I would like to highlight that psychological trauma can occur when a child experiences an event through direct exposure, witnessing it, or finding out that it has happened to their loved ones. Events that are potentially traumatic can be roughly divided into 4 categories, such as disaster, and an example of it would be a fire or an earthquake, accidents such as being knocked down by car, bicycle, or even PMDs, personal mobility devices, difficult interpersonal experiences such as being bullied or sexual or physical abuse, medical experience such as undergoing uncomfortable and scary medical procedure in a hospital. Please note that this list is not meant to be exhaustive, so any events that the person perceives to be overwhelming for their capacity to cope and perceived to be threatening can be a traumatic event. There are many factors that contribute to the development of traumatic stress symptoms, and they include, number one, severity of the event. How badly was the child or someone they love physically hurt as a result of the event? Did the child or their loved one have to go to the hospital? Number two, proximity to the event. Did the child experience the event as a victim, or did they witness the event happen to someone that they loved? Number three, caregiver's reaction. How did the caregivers respond to the child's needs? And how did the caregiver cope with the event themselves? Number four, prior history of trauma. Children who have been continuously exposed to traumatic events are more likely to develop traumatic stress reactions. Last but not least, family and community factors. Does the child and family members have resources that would actually help them to buffer against the harmful effect of traumatic experiences? Now, I would like to take the chance to answer the poll question that we attempted at the start of the session. The question posted to you was, children with serious physical injuries are more likely to experience psychological trauma. True or false? And the answer is, well, neither. Right? This is a trick question that I've posted to you guys. Because the answer is, it depends. By now, we actually know that whether a child perceive an event to be threatening is really based on their subjective experience. Did they find it to be life-threatening? Did they feel like it's overwhelmed their capacity to cope with the event, right? So it's really based on the perception of the child, right? Whether one experienced psychological trauma as a result of a stressful event. The other thing that we know as well is that higher severity of physical injury actually does not lead to the increased likelihood of a child developing psychological trauma. Now, from this slide, we know that severity of the event is one of the risk factors that contribute to the development of traumatic stress symptoms. And sometimes, unfortunately, more severe events does cause children to experience more severe physical injury. I think you guys would agree with me on this. Sometimes this is the way things are, right? So as a medical professional, my advice to you would be, do look out for traumatic stress reactions in children who have more severe physical injury, not because higher level or higher severity of physical injury is positively correlated to higher likelihood of developing traumatic stress symptoms, but rather because the severity of an event is a risk factor that might contribute to the development of traumatic stress symptoms. And sometimes, unfortunately, like I've shared, more severe events does lead to children experiencing more physical injuries. Now, let's see how the risk factor can be applied to this 10-year-old boy that we are using in our case discussion. I will only be covering the child characteristic, caregiver's reaction, and family factors on this slide, as I think the rest of the factors are quite self-explanatory. So usually for a 10-year-old child, developmentally, they should be at a stage where they should be able to easily report the symptoms that they are experiencing to you. However, due to this child's characteristic, for this case, we actually have to rely quite a lot on the observation made by the caregivers and the nurses who were caring for him in the ward. So pre-morbidly, even prior to the road traffic accident, this boy was described by his mother to be incredibly shy and reserved. The only people that he speaks to are his immediate family members. And in terms of social support, he actually has no close friends in school. One important thing that I do want to highlight is that not all 10-year-old children are like him. It really depends on the child characteristic, on helping us to understand what he's experiencing. The other points that I want to highlight is the caregiver's reaction. So for this patient, his father was actually quite anxious and has a lot of worries about his physical injuries and also his traumatic stress reaction. So sometimes dad might not be able to contain his emotions so well in front of the boy, and this in turn can have an impact on how the child is coping with his traumatic stress reaction in the ward as well. One other important point that I do want to highlight is that caregivers can sometimes experience traumatic stress reactions as well. These reactions are normal responses in reaction to a very abnormal event, very unexpected event, such as the road traffic accident. Usually with support, they do get better within a few days or within a month. However, if the symptom persists more than a month, you may want to think about linking the parents up with professional support. Last but not least, family and community factors. From what we understand from the family, there wasn't much support that was coming from the extended family. The boy's two elder sisters have actually witnessed the road traffic accident as well. And they were linked up with school professionals that were monitoring them in terms of any emotional or behavioral changes following the road traffic accident. Here are some common traumatic stress reactions that are experienced across the different age group. So for feelings, children might report that they feel scared all the time. For thoughts, they might report that they keep thinking about the incident that happens to them. For bodily reaction, they might report pain and aches in their body that are unrelated to any medical reasons. For behavioral changes, sometimes children can report difficulties falling asleep at night, or they might tell you that they are suffering from poor appetite in the ward. For younger children, due to where they are at in terms of their developmental phase, they tend to display more behavioral symptoms, examples such as increased tantrums or regressive behaviors. This is more so as compared to school-age children or teenagers. So based on the information that is covered in the last couple of slides, we now know that trauma reactions are so diverse and is really related to our subjective perception, right? So then how do we know whether a child has PTSD or is experiencing traumatic stress reactions? We conduct trauma screening. And the importance of trauma screening really lies in getting the child's subjective experience. The child's trauma screening questionnaire, which is known as the CTSQ, is a questionnaire that we use in trauma screening. It is a 10-item questionnaire and is intended for use for children aged 7 to 16 years old. Yes, as a response, is scored as 1, and no, as a response, is scored as 0. A score of 5 or more is actually a best predictor for development of PTSD in the later days. In the resource document that I'll be sharing with you guys, I have included a link to the CTSQ, but please note that the CTSQ is not a diagnostic tool. If you have any concerns about your patient, please refer them to the psychologist. Fortunately, most children do not go on to develop PTSD, and only a small percentage of 15 to 25% of them will experience persistent traumatic stress reactions. And when this problem occurs, they can impair a child's day-to-day functioning, and it can affect the child's adherence to medical treatment or affect their optimal recovery. This is why screening for traumatic stress reactions in the medical setting is important. It ensures that children who are experiencing traumatic stress symptoms will receive the professional support that they need. With support from family and friends, most children do feel better within a few days or a month. However, if a child continues to experience this reaction 1 month after the event, this suggests that they might need further professional support. So please refer them on if this is the case. Here's a summary of the important learning points that we have covered so far. Firstly, psychological trauma is not just an event. It involves the individual subjective experience of the event. Secondly, only a small percentage of children go on and develop PTSD. So please refer the child for further assessment if their traumatic stress reaction persists 1 month after the event. Thirdly, psychological and physiological factors can interact with each other, impacting on the child's recovery. And last but not least, beside the child's subjective experience, Parental and family characteristics are important factors that determine the development of PTSD as well. Thank you for attending this session. I hope you find this session helpful for your learning.
Thank you very much, Ms. Sin-Er, for that very enlightening talk. I'm Dr. Kim Epino. I'm the current lead for the Pediatric Pain Special Interest Group of ASPA. So I will be introducing our last, but definitely not the very least of our speakers. Allow me to introduce Ms. Joanne Specterman. She is the principal psychologist at KK Hospital. Her current interests include pediatric chronic pain, as well as families with adverse childhood experiences. So her talk is entitled Beyond the Pain, Psychosocial Approaches in Pediatric Chronic Pain. We just have a poll question here to start off her talk. Which factor is linked to a higher prevalence of chronic pain in children and teens? Is it anxiety, depression, self-esteem, low SES, or all of the above? We encourage all attendees to plug in your replies or answer to our poll question. Okay, so the answer is all of the above. Can I ask our speaker to give us a further elaboration or enlightenment on these responses?
Thank you very much. Thank you for doing the poll. Very interesting, very skewed answers over there. I'm not going to share the response. This was just an opening question to open our minds to how psychological issues and other social issues can also impact pain. So the answer will be somewhere in my slides later on.
All right, thank you very much. The floor is yours.
Thank you. Good afternoon, everyone. Thank you for your time staying on. I am Joanne, psychologist at KK Hospital, Singapore, working with the Children's Pain Management Clinic and Psychology Service. Today, I hope to share some light on the importance of dealing with pediatric chronic pain from the psychosocial lens. Thank you for taking part in the poll question earlier. Before we get to the answer, we want to be aware about the high prevalence rates of chronic pain in children across the countries. Within the limited studies in Southeast Asia, 41% in the Malaysian sample reported chronic abdominal pain and 23% in Singapore. As a comparison, in the US, it is around 11 to 38% reporting chronic pain of various chronic pain presentations. And in a review of studies, 20% reported chronic post-surgical pain after 12 months. They found that a child who is highly anxious, with poor confidence in coping with pain, and with parents who focus and worry about the pain, tend to report chronic pain. So back to the poll question. In a review in 2011, which factor indicated higher pain prevalence in the general pediatric population across multiple studies? Well, they found all of the above: anxiety, depression, low self-esteem, and low SES, along with other chronic health problems, were all connected to a higher pain prevalence across studies. And these studies look into various pain areas like abdominal pain, musculoskeletal pain, and even headaches. So all of these point to the essential use of the biopsychosocial model to understand chronic pain, where a complex interplay of physical, psychological, and socioeconomic factors modulate a patient's report of pain symptoms and functioning. Indications of a biopsychosocial direction to explain pain was picked up in a gate control theory of pain in the 1960s by Ronald Malzak, a psychologist, and Patrick Wall, a neuroscientist. And it is with this model that our team and I use to explain to our patients in layman terms. We tell them there are gates in the nerves pathway that controls how much pain signals go up to the brain. If there are more non-painful input, like feelings of relaxation, feeling calm, positive responses from enjoyable activities, all of these can override the pain signals and hence closing the pain gate. And we show our patients a list of these factors in a table like this. So in our case study, it will be interesting to note whether he does more things in the left column, things that increases the pain, or the right column, things that lessens the pain. Setting time to ask the child and parents about these areas will be helpful. And often the discussion starts with broad questions of his daily routines, what he or the parents think about the pain, how they feel when the pain comes up. And we're not looking for specific black and white responses, whether he is worried or not, but rather, for example, they can still worry at times, but are they generally coping with the worries? Are they slowly getting back to the usual lifestyle, even with the pain? By taking rest breaks in their activities? Are they also proactively trying new ways to deal with the pain? And this helps them to gain some sense of control of the pain, rather than feel overwhelmed with the pain. So if our patient is doing more things from the left column in the red box and has recurrent pain for the last 2 months, he is likely not coping well with his pain, and his pain is likely to persist more than 3 months. We will suggest to our patient to do more of what is in the green column. So for example, engaging in their usual enjoyable activities with sufficient breaks in between, and focusing on what they had found meaningful rather than focusing on the pain alone. But if he has difficulty doing all these, the patient will be best referred to psychology, physiotherapy, or occupational therapy according to their reported difficulties. We also look into unhelpful caregiver responses because the child spends most of their time with the caregivers back at home. So based on this pediatric version of the fear avoidance model of chronic pain, how the child responds to the pain experience is influenced by how the caregiver responds and manages the child's pain at home. If there are unhelpful caregiver responses and the behaviors are listed in red, like the parent being anxious, keeps asking about the pain, or becomes overprotective, not letting the child do various things due to possible pain, then the child will also unlikely to accept the pain experience and will be more fearful, more avoidant of pain, avoiding school, activities, and movement. This leads to decreased functioning and more persistent pain. These are a list of questionnaires to screen for mood or anxiety, as well as how much the parent and child worry about the pain. The ones highlighted in black blue are the ones I would likely give to the patient in our case study to screen at a juncture of 2 months of having persistent pain. My colleagues in the pain clinic also give this out even when I'm not around, and also help to interpret the scores and inform me in due time or to be seen urgently. A good time to refer to a psychologist is when there are significant mood difficulties and anxiety, and all these are impacting the child's functioning, or the patient continues to use maladaptive coping strategies, despite being told otherwise. And he tends to avoid activities, movement, and this is increasing. When talking to the child and caregivers about the psychologist referral, it is important to set the tone. That a psychologist referral doesn't mean the pain is not real. It also does not mean the child is crazy. Do acknowledge that their experience of pain is real, their suffering is real, and a psychologist referral is needed when the pain is overwhelming and affecting the child's activities, feelings, and thoughts. Attending psychology sessions is part of the plan to manage the physical factors of pain and to gently increase functioning, even if pain is ongoing. So what if there's no psychologist within your team, or it might take some time for them to see a psychologist from a different hospital or place? And there are some things we can be doing when the pain starts to be a problem. First is to inform parents and the child the importance of acknowledging the pain is real, emphasize stress management and worries about the pain, pacing during activities, encourage relaxation, and control screen time. There are also a series of websites, an app, and books to help guide these families in managing chronic pain. And that's a very short overview of what we can do in managing pain from a psychosocial lens. And just some references. Thank you so much for listening. Good afternoon, everyone.
Thank you very much, Joanne, for that very insightful discussion on psychology's role for chronic pain patients. I'm just sharing here the QR code for our online resources that our speakers have shared for this evening session. So now we're going to officially open our panel discussion. Dr. Kim, yes?
Thank you very much for all those excellent talks. I learned a lot just, from the back end. Why don't we start with some of the questions in our Q&A box that some of our speakers marked as they will answer live. So I think this one is for Dr. Albert. So I would like to ask, what is a pitfall on therapy of pain for pediatrics?
I think it's important to recognize that pediatric pain is commonly undertreated, and really the reason behind that could be multifactorial, including just like providers feeling uncomfortable how to assess and prescribe a comprehensive treatment plan, and resulting from it in the chronic pain clinic, what I hear a lot from my patients is many times they felt dismissed by the medical system, and that has actually become a source of trauma and anxiety for these patients. So it's important to address pain in children and consult other specialists if you're unsure how to address it.
Yeah, very well said. Thanks for that. I'll just deviate a bit just to pick up on your reply or your answer when you said that some of these children feel that they don't feel heard. Can we ask just some of our psychologist speakers if there are some techniques that you could teach us on how to not present ourselves as dismissive towards children's complaints of pain?
I think either Sin-Er or Joanne can chime in on that. How to be more child-friendly? Maybe the best way to put it in.
I think it's natural to feel quite anxious, or quite worried, or perplexed, or confused when you have a child in pain. And I think it's okay to have these feelings inside. But on the outside, we still want to present as calm as possible. I do tell my parents sometimes that I see in the clinic to be the Emmy Award-winning people you can be, or actor actresses in front of the children. So we talk low and slow as well. We also want to approach the situation in a more curious approach. So being curious why the child is still screaming like this, or commenting on this, or complaining about this, even though there seems to be no reason or cause for the pain at times.
Mm.
So going from a curious approach will help to sort of validate the child's responses, and yet still keep an open mind on what could be happening to the child.
Yeah, because there's a lot of question also about parental involvement and how we are actually going to encourage them to be part of the treatment rather than spectators of the treatment, right? So I think maybe I should ask Sina regarding this question, because you mentioned about the 1 month time frame, right? But we've seen number of post-traumatic patients or post-trauma patients who require certain assistance as early on in acute phase of their pain experience. So is there any, let's say, for example, if the patient is inpatient, just recovery, how early should we actually refer to a psychologist in terms of post-traumatic experience? Should we wait for the 1 month, or could be earlier than 1 month?
Actually, it can be earlier than the 1 month. And I think I would like to differentiate between traumatic stress reactions, like how we've mentioned that actually traumatic stress reactions are very normal reactions and responses that someone have in terms of a very abnormal or very unexpected event that has happened to them. And usually with support, that means with screening and with psychoeducation that the psychologist can come in and do, usually children do recover from these symptoms within days or months, within days or sometimes within a month of their event or injury or traumatic event. What tells us that they need more support is that 1 month after the event, if they still continue to experience the traumatic stress reaction, despite the coping strategies, despite the psychoeducation that has come in to support them during the acute of their admission, they're still experiencing that, it tells us that they require more intensive support, and that's where a referral might be necessary. So you do not have to wait until 1 month to refer. As long as the medical team and the parents or even the child is reporting some of these traumatic stress reaction to you, actually a referral can come in and a psychologist can already go in and screen and support the child even during the acute phase of their admission. The only differences is sometimes when children are in ICU, depending on how severe their injury. In ICU, it might be a little bit hard because they are not awake most of the time. Usually the screening support comes in while they are in HD, where they are a little bit more awake, they're a little bit more conscious and able to explain and share a little bit of the symptoms that they're experiencing so far. So to answer your question, Teddy, don't have to wait until 1 month to refer for psychologist support.
Thank you very much, Sin. I think there's quite a lot of questions for Dr. Lai Peng in the chat, in the Q&A box, particularly in the intranasal and intravenous and all of the route of our pain relievers that we administer to our patients. Couple of questions. Will there be alternative? Can I use the IV preparation to give intranasal? Can I give the IV preparation to give it as oral? Or all of these alternatives that they can use in children's emergency? Dr. Lai Peng, please.
Yeah, so for the question on if they do not have that particular formulation, so actually for the intranasal, right, we are using the same as the IV fentanyl, but definitely if you are using intranasal, you need the atomizer. So basically the syringe, be it 1 ml or 3 ml, is actually attached to an atomizer to be given, and you give it as small squirts into each nostril. You divide between the 2 nostrils to complete the dose.
Any tricks on how you administer your intranasal, Dr. Lai Peng? I'm sure sometimes, right, all of us could be quite challenging, particularly in the patient is stressed and crying and all that. Any tips and tricks?
Yes,
Yeah,
how
so
do you hold them down?
Yeah.
Okay, so the thing is to really explain to them, to tell them, don't be frightened. It's not painful. It's like putting, like a nose drop into your nose, and you just tell them it's not sharp, and then start gentle. because anyway, you cannot push a big volume in. It will just flow as a post-nasal drip if you push a big volume in. So it's actually just a gentle squirt. So if you give it as a gentle squirt, usually I'll just direct it for the right nostril towards the right eye. So it's actually giving towards the side rather than giving straight up, like the way we would give our intranasal steroids. So because partly it's uncomfortable, partly it's also that fear something is going inside their nose. So I think the main thing is before you put it in, to just let them know that this is not painful and you're going to do it very slowly. Let them have a feel how it's going to feel like. Yeah.
Thank you, Dr. Lai Peng. I think now we move on to Albert. There's a question. Do you want to share your recipe for immediate post-op pain relief? Let's say for this case, going back to the case, polytrauma, went in for surgery, and now coming in for you're the one in charge in planning the post-op pain regimen for this patient. What do you think you would recommend in terms of pharmacologic approach for the patient? Yeah.
Like I mentioned, opioid is still the workhorse of analgesia. So it's very important to select an appropriate opioid plan for the specific patient. And the institution, considering what monitoring practices and what is on formulary at the institution, but also some of the more easier and common non-opioid adjuvants, such as acetaminophen or paracetamol. If NSAIDs are okay, as long as there's no contraindication, those should be implemented. If the institution is fortunate enough to have a regional anesthesiologist discussing whether there's a nerve block or a catheter placement that could help decrease the opioid requirement, would be very beneficial. And other non-opioid adjuvants that we mentioned briefly today, it also involves a lot of careful planning and education of providers, nurses, and pharmacists. So I would probably work on those to try to include it. Unfortunately, there's no researched protocol for trauma and pediatric trauma specific protocol. But employing a multi-modal treatment is key, and involving other specialists such as pain psychologists and rehab specialists and other specialists of medical specialties when appropriate, and being able to recognize that is the first step.
I think there's a second question in the same question or from the same person. The follow-up to that is, would you be managing, or how would you manage differently a post-operative child who had trauma versus one who had surgery but not necessarily due to a traumatic event?
I think patient with polytrauma, because of the extent of injury, there's much more to consider, and there may be other organ injury that happened from the traumatic force. So it's you just have to be able to adapt the plan and recognize which part of the multimodal pain treatment is contraindicated. So the more toolkit you have in the toolbox of treating pain, you're going to be more effective and nimble in treating the pain, because you have to adapt to the scenario very fast.
Thank you very much, Dr. Albert. I think I'll go back to Dr. Lai Peng regarding the controversy of when is the best time to administer your narcotics for trauma patient. If you are actually, is it because sometimes the patient will come in very severe pain, like the patient that we just presented, and you haven't done your secondary survey yet. So when is the best time? Do you need to wait for all of the surveillance to come in, all of the scans to be up before you can give your narcotics, or you can give your narcotics ahead of time? Dr. Lai Peng?
Yeah. Actually, eventually it's the risk benefit assessment, because in the major trauma, if the patient is very unstable, you need to manage the airway, the breathing, the circulation. All this needs to be sorted out first, because the IV opiates definitely by itself can actually worsen the respiratory depression and the hemodynamic instability. So you need to make sure your fluids, the bloods, the airway is done. But of course, as you are doing all this and the patient is still conscious, then you need to provide some form of analgesia, because the stabilization process can actually take maybe 20 minutes, 30 minutes. And as long as you have your blood on board, you can still give the analgesia in judicious dose. So for those patients whereby they are very stable, so for example, they have only a muscular skeletal injury like a fracture of the femur, it's very, very painful. But hemodynamically in children, they can be very stable. So in those cases, actually, I don't think there's that worry about opiates, as long as the dose is within the limits. And you can always start with a lower dose first, and then you can titrate until the pain is better managed. There are different modalities, as we have mentioned earlier on. IV paracetamol can be very useful as well.
Yeah, thank you very much, Dr. Liping, for clearing that to our viewers. I go back to our psychologists. I think there's a challenge here when it comes to the age of the patient, right? There's a preschool age is quite tricky because they are already expressing some support, requiring support and all that, but I'm not so sure what's the youngest age that can benefit. Maybe I'll start with Joanne with regarding the chronic pain treatment in the clinic basis. What do you think is the youngest, or what's the youngest age that you can actually say that, okay, this one can qualify in our clinic and we can actually take care of this patient?
We haven't really put an age limit on who we can see. Obviously, we are looking at maybe 1 or 2 years older, 2 years old and above. But to be honest, in our chronic pain clinic, we don't see that younger children. We see primarily like those in 7 years and above, to be honest. And the reason being is that most of them will go through several doctors' appointments, specialties to rule out different things. And then it may take months or even years sometimes before coming to our clinic. So they're much older when they present themselves in the clinic. But yeah, so usually, but for the younger ones that we've seen, maybe 5 or 4 years old sometimes, as long as they have 3 months of pain that's been recurring, and more importantly, their functioning in their life have been really impacted. So they're not going to school that much, they're not going out with their friends, or are able to go out and do like playground activities, and they're kept really at home, and the parents are also very highly anxious. And we know it's detriment to their family life. So then they'll come to us, and then yes, we definitely want to have them in our clinic. We'll set a referral and we'll see them for follow-up.
Yeah, thank you very much, everyone. I think some of our speakers already keying in the answers to the questions posted in our Q&A box. Unfortunately, in the interest of time, we won't be able to carry on with our panel discussion. But before we formally end, we have a few announcements. I'll hand over the floor to Dr. Kim to invite us for our Pain Awareness Month celebration. Dr. Kim?
Yes, thanks, Teddy. So very excellent speakers and discussion. I was actually sad that the Q&A had to end. I still have a few questions for myself. Anyway, I'd like to invite our attendees who haven't joined our tribe yet to, oops, I think I missed the QR code, Teddy, to scan, just to scan the QR code on your screens and join us in spreading the good stuff on pediatric pain. At the end of the joining form, please choose a subgroup that you may want to join. I encourage you as well to join our special projects subgroup. Just to start off on my next announcement. So I'm joining everyone to join us in recognizing September as Pain Awareness Month by celebrating a Pain Awareness Week in your respective hospitals or institutions. It is an opportunity to raise awareness and recognize your institution's efforts in raising the bar on pain management in children. We present expressions of pain as this year's Pediatric Pain Special Interest Group theme, and blue as the celebration color. In the next few days, we will be sending out emails and posting in the PPSIG group chat suggested activities to celebrate Pain Awareness Week. So thanks for being with us today, and thank you, ASPA, for the support and for giving our SIG a platform to share knowledge and insights in pediatric pain. Back to you, Teddy.
Thank you very much, Dr. Kim. Before we end, I would like to invite everyone for our next webinar coming September. The webinar is Navigating Anesthesia Challenges in a Cath Lab, Sedation versus General Anesthesia, Managing Procedural Risk. So this is actually brought to you by the Cardiac Special Interest Group of ASPA. We have speakers from various countries like Turkey, Vietnam, USA, Japan. And to register, please scan the QR code. April 4 to 5, 2025, we are coming to Kathmandu, Nepal, for our ASPA conference. So we invite everyone to please join us. Scan the QR code for registration and for abstract submission. So ASPA is a nonprofit organization, and the mission is to foster the highest standard of pediatric anesthesia care in Asia. Hence, we invite everyone to please scan the QR code and donate. Again, thank you very much. See you next month. Have a pleasant evening to all.
Thank you, everyone.